Hello everyone, I am Mohammed Hamama, and this is your ASCP preparation camp. In this camp, we will go through each topic on the ASCP lecture list. In today's video, we delve into the world of acute leukemias, exploring their origins, causes, and development. Join us to gain a deeper understanding of this complex hematologic disorder. But first, let's explore the origin of the term leukemia. The word leukemia traces its roots back to Greek words meaning white and blood. Now, let's move on to the basics of acute leukemia. Acute leukemia is characterized by the rapid overproduction of lymphoid or myeloid progenitor cells, namely lymphoblasts and myeloblasts, right in the bone marrow. When these blast cells multiply excessively in the bone marrow, they spill over into the bloodstream, leading to various symptoms caused by the disruption of normal blood cell production. But what causes acute leukemia? Well, the direct causes of most cases remain a mystery. However, specific toxins can induce genetic changes associated with malignancy. Environmental exposures, such as radiation and organic solvents like benzene, have been linked to an increased risk of hematopoietic malignancies, including leukemia. In rare instances, leukemia may occur in individuals with familial cancer predisposition syndromes, shedding light on the genetic aspect of this disease. It's also essential to note that certain cancer treatments, like alkylating agents and chemotherapy, can damage DNA in hematopoietic cells, potentially leading to therapy-related leukemias. So, how does leukemia develop? It's a multi-step process involving genetic mutations that give cells a proliferative advantage while hindering their differentiation. Ultimately, these mutations transform normal hematopoietic stem cells or precursors into leukemic stem cells, which drive and sustain the leukemia. FAB classification, French-American-British. In the world of leukemia diagnosis, classification is key. Join us on a journey through time as we compare the FAB classification of the 1970s to the contemporary WHO system. It all began in the 1970s when hematologists needed a way to classify leukemia. The FAB classification was born, focusing on cell morphology and cytochemical stains. The primary goal of FAB? To distinguish between lymphoblasts and myeloblasts, helping doctors pinpoint the type of leukemia. Even today, cytochemical stains remain valuable tools for identifying hematopoietic diseases, especially acute leukemias. But hematologists and pathologists have evolved. Now, they combine morphologic and cytochemical assessments with advanced techniques like flow cytometry and genetic studies. The shift is towards precision, based on recurring chromosomal and genetic abnormalities often seen in patients. These anomalies affect key cell functions. Enter the World Health Organization, WHO, classification in 2001, revolutionizing leukemia diagnosis. The WHO system incorporated elements of older schemes like FAB but introduced new categories for leukemias linked to consistent chromosomal changes. According to WHO, most acute leukemias require at least 20% blast cells in the bone marrow for diagnosis. Genetic testing is crucial to detect specific anomalies. The WHO wasn't done evolving. In 2008, it revised its classification to keep pace with scientific advancements. We must note that discussing each subclassification is quite extensive. Our focus remains on the most prevalent types, acute lymphoblastic and acute myeloid leukemia. Now we're diving into acute lymphoblastic leukemia, or ALL. Let's get started. Prevalence and age distribution. ALL primarily affects our youngest warriors, children, and adolescents. In fact, it makes up a significant portion of childhood cancers. Would you believe that up to 75% of childhood leukemia cases are ALL? It's truly impactful. The highest incidence? Well, that falls between the ages of 2 and 5. But hold on, there's more to the story. While ALL is rare in adults, the risk increases with age. Most adult patients are older than 50. Now, let's talk about what influences your journey through ALL. The specific subtype of ALL is a crucial player in predicting your survival. But here's a fact check: for adults, the outlook isn't as rosy. About 80% to 90% achieve complete remission, but the cure rate? It's below 40%. Symptoms and clinical presentation: B-cell ALL. What does it feel like to battle B-cell ALL? Well, let's break it down. You might experience fatigue, thanks to anemia. Then, there's that persistent fever due to neutropenia and infection. Mucocutaneous bleeding? Yep, that's from thrombocytopenia. Lymphadenopathy is a fancy term for enlarged lymph nodes, a common sign. And don't forget the splenomegaly and hepatomegaly, that's enlargement of the spleen and liver. Bone pain. It's often a result of leukemic cell growth within the bone marrow. And sometimes, those malignant cells infiltrate the meninges, testes, or ovaries. You might even find lymphoblasts in the cerebrospinal fluid. Symptoms and clinical presentation, T-cell ALL. T-cell ALL. It's got its own unique presentation. Picture this, a large mediastinal mass that can affect nearby structures. Anemia, thrombocytopenia, organ enlargement, and bone pain are still in the mix, though leukopenia is often milder. Let's take a quick dive into the World Health Organization classification. BALL gets divided into 7 subtypes based on those recurring cytogenetic abnormalities. And if B-cell ALL doesn't have specific genetic abnormalities, it falls under the not otherwise specified category. Now, TALL. It's not further divided clinically, as specific genetic abnormalities aren't as clear-cut. Next, we're delving into the fascinating world of leukemia morphology and prognosis in acute lymphoblastic leukemia, or ALL. Let's dive in. First, let's talk about morphology, the study of cell structure. In ALL, lymphoblasts come in 2 distinct sizes. There are small lymphoblasts, which are 1.0 to 2.5 times the size of a normal lymphocyte, and larger lymphoblasts, 2 to 3 times larger. Interestingly, these cells can sometimes be mistaken for blasts seen in acute myeloid leukemia, or AML. Now, let's shift our focus to the prognosis of ALL. Advances in treatment have significantly improved the outlook for ALL patients. Prognostic factors play a pivotal role: age at diagnosis, lymphoblast load, immunophenotype, and genetic abnormalities. Interestingly, children tend to have better outcomes than infants or teenagers. But watch out for chromosomal translocations, they're strong predictors of unfavorable outcomes in both children and adults. Additional factors linked to worse outcomes include high peripheral blood lymphoblast counts, hepatosplenomegaly, and lymphadenopathy. It's worth noting that factors like sex and ethnic group no longer affect prognosis when patients receive equal access to treatment in clinical trials. Distinguishing ALL from AML. One critical task for hematologists is distinguishing between acute lymphoblastic leukemia, ALL, and acute myeloid leukemia, AML. Both B and T cells originate from lymphoid progenitors and typically express specific markers. Now, let's break down the 4 types of ALL based on immunologic methods. There's early BALL, pro-B or pre-B, intermediate, common, BALL, pre-BALL, and TALL. In this segment, we'll explore the distinct characteristics of B-cell acute lymphoblastic leukemia, or BALL, and T-cell acute lymphoblastic leukemia, or TALL. Let's start with BALL. It's marked by specific B-cell antigens expressed at various stages of B-cell development. These cells typically express CD19, CD20, CD22, CD24, C79A, CD10, cytoplasmic M, and PX5. Interestingly, the degree of differentiation of B-lineage lymphoblasts is often tied to genetics and can influence treatment decisions. Pro-B-ALL, for instance, expresses CD34, CD19, cytoplasmic CD22, and TDT, signaling an earlier stage. Intermediate BALL expresses CD10, indicating a mid-stage in B-cell development. Pre-BALL is the most mature stage, usually with negative CD34 and characteristic cytoplasmic M heavy chain expression. Now, let's shift our focus to TALL. It's more common in teenage males and often has a distinctive presentation. Patients may present with a mediastinal mass, elevated peripheral blast counts, meningeal involvement, and extramarrow infiltration. T-cell markers CD2, CD3, CD4, CD5, CD7, and CD8 are usually present. And most TALL cases express TDT, which is essential for their diagnosis. However, there's a unique subtype called ETPALL, or early T-cell precursor ALL. ETPALL has a distinct immunophenotype, CD8-, CD5-dim, and typically responds poorly to chemotherapy, leading to low remission rates and overall poor survival. Moving on to genetic and molecular findings. Cytogenetic abnormalities are commonly observed in both B and T cell ALL and play a crucial role in their development. In TALL, Notch1 gene mutations are frequently found, altering the Notch receptor signaling pathway involved in normal T cell development. Now, let's talk about prognostic factors. TALL cytogenetic alterations are less specific and show fewer correlations with prognosis compared to BALL. Philadelphia chromosome positive ALL, BCR-ABL1 mutation, has the worst prognosis. It's more common in adults and can be treated with imatinib. On the other hand, BALL with translocation of V11 with Q23, MLL rearrangement is common in very young infants and carries a very poor prognosis. However, ETV6-RUNX1 translocation, seen in about 25% of childhood all cases, has an excellent prognosis in children but is rare in adults. Hyperdiploidy in childhood BALL, found in 25% of cases, is associated with a favorable prognosis. Conversely, hypodiploidy, with fewer than 46 chromosomes, indicates a poor prognosis in both children and adults. Now we're delving into acute myeloid leukemia, or AML, covering everything from incidence to clinical presentation. AML is a prevalent type of leukemia in adults, and its incidence tends to rise with age. However, it's less common in children, making it crucial to understand its classification in clinical presentation. In the past, AML was classified using the French-American-British system, primarily focusing on morphology and cytochemistry. But now, the World Health Organization, WHO, classification relies heavily on cytogenetics and molecular characterization. The clinical presentation of AML doesn't come with specific symptoms but is marked by a reduced production of normal bone marrow elements. Most AML patients have a total white blood cell count between 5 to 30 billion per liter, but it can vary widely. Symptoms include pallor, fatigue, fever, bruising, and bleeding, all resulting from anemia, thrombocytopenia, and neutropenia. Disseminated intravascular coagulation and bleeding abnormalities can be significant, and malignant cell infiltration may affect the gums, mucosal sites, and skin. Let's talk about organ involvement. Around half of AML patients may experience splenomegaly, although lymph node enlargement is rare. Intriguingly, cerebrospinal fluid involvement in AML is rare and less ominous compared to other types of leukemia. Common laboratory abnormalities in AML include hyperuricemia, which stems from increased cellular turnover. Hyperphosphatemia also occurs due to cell lysis, and hypocalcemia is frequently observed during presentation. Notably, hypokalemia is a common finding in AML patients. Now, let's discuss a critical complication during AML treatment, tumor lysis syndrome. This syndrome can occur during induction chemotherapy, especially when patients have elevated WBC counts. It's a group of metabolic complications stemming from the breakdown products of dying cancer cells. Key features include hyperkalemia, hyperphosphatemia, hyperuricemia, hyperuricajuria, and hypocalcemia. Hyperkalemia, in particular, poses a life-threatening risk. Preventative measures are crucial to reduce or prevent the clinical manifestations of tumor lysis syndrome. To the discussion of the subtypes of acute myeloid leukemia, AML, and related precursor neoplasms. First on the list, AML with T8, 21, Q22, Q22, RUNX1/RUNX1T1. It's found in about 5% of AML cases, primarily in children and young adults. Myeloblasts here exhibit dysplastic granular cytoplasm, Auer rods, and some maturation, resembling Fab-M2 classification. Prognosis is generally favorable, but additional abnormalities like monosomy 7 can have a negative impact. Diagnosis is based on the genetic abnormality, regardless of blast count. Next, we have AML with INV, 16, P13.1 Q22, or T16, 16, P13.1, Q22, CBFB, MYH11, representing 5 to 8% of AML cases, often in younger patients. Again, the genetic aberration is diagnostic, no matter the blast count. Peripheral blood and bone marrow may show myeloblasts, monoblasts, and promyelocytes. AML with this mutation might lead to eosinophilia and dysplastic changes in the bone marrow. There's also a higher incidence of extramedullary disease. Moving on to a unique subtype, AML with T15, 17, Q22, Q12, PML rara, commonly known as acute promyelocytic leukemia or APL. This accounts for 5 to 10% of AML cases and can affect all age groups, with a differentiation block at the promyelocytic stage. Diagnosis is confirmed by detecting the 15, 17 translocation, and patients might exhibit thromboembolic events due to procoagulant activity. Treatment involves all transretinoic acid, ATRA, and arsenic trioxide, offering an excellent prognosis in adults achieving complete remission. Let's talk about AML with T, 9, 11, P22, Q23, MLT3, MLL, a rare leukemia representing 6% of AML cases and predominantly found in children. This type is characterized by an increase in monoblasts and immature monocytes with large cytoplasm and fine nuclear chromatin. It's often associated with gingival and skin involvement and/or disseminated intravascular coagulation, making the prognosis intermediate to poor. Lastly, there are some other rare AML subtypes. While these are part of the 2008 WHO classification, we won't dive into details in this video due to time constraints. In this part, we'll delve into some specific subtypes and related neoplasms that play a crucial role in understanding this complex disease. Let's begin with AML with myelodysplasia-related changes. This subtype primarily affects older adults and comes with a rather challenging prognosis. It encompasses leukemias with specific characteristics, including at least 20% blasts, multilineage dysplasia, a history of myelodysplastic syndrome, MDS, or MDS/myeloproliferative neoplasm, MPN, and specific MDS-associated cytogenetic abnormalities. Dysplastic features are observed in various blood cell lineages. These include pancytopenia with abnormal neutrophils, erythrocyte precursors with unique characteristics, and dysplastic megakaryocytes. Moving on to therapy-related myeloid neoplasms, these arise as a result of treatment with certain agents and account for a significant percentage of AML cases. They can develop after treatment for prior malignancies or even intensive cytotoxic therapy for non-malignant disorders. Morphologically, they can resemble various AML subtypes and are generally associated with a poor prognosis. Now, let's discuss acute myeloid leukemia, not otherwise specified, or AML, NOS. This category houses AML cases that don't fit neatly into specific WHO subtypes. Diagnosis here relies on various factors like morphology, flow cytometry phenotyping, and limited cytochemical reactions. Initially, a significant portion of AML cases fell under AML, NOS, but as we identify more genetic subgroups, this number is decreasing. Please don't forget to subscribe to our channel, activate notifications to get our new videos. If you like our content, please press the like button, and share the video with your friends. If you have any questions, leave a comment below. Welcome back to our comprehensive journey through the world of acute myeloid leukemia, or AML. Now, we're delving into specific subtypes that provide valuable insights into this complex disease. Let's start with AML with minimal differentiation. This rare subtype affects both infants and older adults. It's characterized by unique blast markers and a lack of clear cellular maturation. A key feature is the absence of our rods, blasts that express CD13, CD33, CD34, and CD117, and negative results with myeloperoxidase and Sudan black B stains. Now, onto AML without maturation. This subtype shares some blast markers with AML with minimal differentiation. In fact, about 70% of cases express CD34. Blasts are prominent in the bone marrow, and our rods are present. Positive results are obtained with myeloperoxidase or Sudan black B stains. Moving forward, we have AML with maturation, a more common AML variant. This subtype features 20% blasts with evident maturation toward the neutrophil lineage. Our rods and dysplasia are often observed. Now, let's explore acute myelomonocytic leukemia. This variant is marked by a notably elevated white blood cell count. Both myeloid and monocytoid cells are present in peripheral blood and bone marrow. Monocytic cells express a variety of antigens, distinguishing them. We'll now delve into acute monoblastic and monocytic leukemias, divided by the maturity of monocytic cells. These leukemias are rare, more common in younger individuals, and often involve extramedullary sites. Next up, acute erythroid leukemia, featuring two distinct subtypes. Dysplastic features in red blood cell precursors are a notable hallmark. This leukemia presents with unique characteristics in the peripheral blood. Acute megakaryoblast leukemia. Our final stop is acute megakaryoblast leukemia, characterized by varying sizes of megakaryoplasts. Accurate diagnosis is essential, distinguishing it from related cases. Immunostaining with specific antibodies aids in identifying megakaryoplasts. We're diving deep into the fascinating realm of cytochemical stains and their interpretations in the context of leukemia diagnosis. First up, let's talk about myeloperoxidase, or MPO, a crucial enzyme found in the primary granules of granulocytic cells. MPO is our tool to distinguish between blasts in acute myeloid leukemia, AML, and those in acute lymphoblastic leukemia, ALL. In AML, myeloblasts typically test positive for MPO, with more than 80% showing activity. Our rods, those distinctive structures, also light up with strong MPO positivity in leukemic blasts and promyelocytes. On the flip side, lymphoblasts in ALL are MPO negative. Moving on to Sudan black B staining, a powerful tool to differentiate AML from ALL by staining cellular lipids. Neutrophils are the stars here, showing positive SBB staining from myeloblasts to mature granulocytes. And the intensity of staining increases as these cells mature. However, monocytic cells may show negative to weak staining due to differentiation changes. Lymphoid cells, on the other hand, generally do not stain with SBB. Finally, let's delve into esterases, another set of tests to help us distinguish different types of leukocytes. These reactions use specific substrates to reveal the presence of esterases in cells. Naphthol ASD chloroacetate, for example, highlights granulocytic cell staining. While alpha-naphthol acetate, while being less specific, reveals strong esterase activity in monocytes. But wait, there's more. Alpha-naphthol butyrate esterase staining offers a more specific but less sensitive reaction in monocytes. Stay up to date with our latest videos by hitting that subscribe button and activating notifications. Be the first to know when we release new and exciting content. Don't keep all this valuable information to yourself, share this video with your friends who might find it interesting and beneficial. If you have any questions or comments, feel free to leave them down below. Until next time, take care and goodbye.